So this is our the four main complications of cataract surgery cause, which are small pupil, subluxated lenses, decompensated cornea, and hard cataracts. Let's have a look at this first case. This person suffered a blunt trauma from a mango that fell on her eye when she was lying by the swimming pool under a mango tree. So this is what happened. The lens is basically subluxed into the anterior chamber. So you have to do a small rhexis. So only when you have a good rhexis margin can you engage the rhexis with capsule hooks. So do a good hydrodissection, pop it up, and put hooks to stabilize the capsular bag. So once this is done, you can just use, once the bag is well stabilized, you can just use phaco and remove the pieces. You can see that because of the 5 hooks that we have put and not 4, there is more equitable distribution of force, and because of that, that bag doesn't move at all. Bag is absolutely stable. Do a slow and stable IA. And pull the cortex off from the fornix. Once this is done, complete the irrigation aspiration and inject a capsular tension ring. So when you put in the CTR, you make sure to inject it smoothly in one go. Otherwise it might snag the capsule, and this happens many times when the capsular bag rips. So inject it in smoothly, and many a times with generalized zonular weakness, not like a 180 degrees or 270 degrees, just generalized zonular laxity due to trauma, just a capsular tension ring will do the job. In goes the IOL. So I waited to see everything is moving okay. Is the capsular bag stable, or will we have to put in an MEHTA segment? Mandatory air at the end of the case to see everything is good, no vitreous in the AC, and case is over. Now my next talk is in a subluxated case.
Should
like
we
this,
use capsule hooks or simply drop anchor when required in the case of a subluxed lens?
So let's have a look at two
We
cases.
use the
When do you use
femtocataract
capsule hooks, and
system
when do you
to
have to
provide
use
a
a device
perfect
like
4
an anchor?
mm capsule or rhexis.
So, hi Arshul.
This gives us a perfect punched out rhexis.
So this is using
Next we use sodium hyaluronate to create space for us between the capsular fornix and anterior rim of the bag and the cortex it holds.
If you do 50 cases like this,
then we can use capsular hooks which differ from traditional iris hooks in having smooth paddles at their ends to spread the forces applied.
With capsular hooks. This is the main
After
advantage
doing
of
an
having a
INA,
femtosecond laser, not to do
we
grade
then
1
pass
or 2
one needle of a
cataracts.
double-arm ninoproline through a capsular ring segment. Railroad this needle out of the eye and then railroad the second needle 3 mm away from the first one, making sure not to nick the capsule. Position this ring segment after railroading the second suture
segment and then put
in the eye. Tension the ring segment by suturing the two ends and follow it up with a 12 mm capsular tension ring to stabilize the bag in its entirety and then inject the lens.
Now what if you have a poor
What do we do if you have a poor rhexis with a small rim of capsule? Here we can see an aborted rhexis with a femtolaser creating disruption under the capsule rather than at the capsular plane. Now it's time for us to make a good rhexis. We use a sharp rhexis forceps, but in this case the rhexis tries to run away. Even though we can pull it back, the capsular rim left behind isn't good enough for a capsular hook. So in this case, what can we do now? So let's mark 3 mm from the limbus.
So now we are stuck with,
and then let's look at the ASIA anchor, a device fashioned after a boat hook
of capsule
with 2 limbs. We retrieve a double-armed ninoprolene from supplies and thread one end of the needle through the suturing hole of the ASIA anchor and then tie it tight. Railroad the suture out of the eye and position the anchor to support the capsular bag. After we can do a slow being held by its two trailing legs.
And then engage the capsular bag with the ASIA
Adjust
anchor.
the suture tension.
And
then we have to lock the suture in place by passing this needle twice through half thickness of sclera.
With the needle.
So that's once.
Once you tighten the suture after passing it
twice.
to half thickness of sclera,
then you simply tie it tight. This gives you a good capsular bag with adequate tension,
two rounds in
which will hold an IOL.
It gets buried inside the sclera itself.
Now it is time to inject the IOL gently. If you inject it ham-handedly, you might dislodge the anchor. So we inject it slowly on top of an iris repositor and then dial it carefully into the bag.
Now the lens is well centered.
This gives us the desired result.
And the case is over. So these are the two cases that I wanted to show. Who wants to go next? Harshul. So introducing Harshul, young and dynamic surgeon and the head of Life Beyond Ophthalmology, which I think is as popular as the whole conference itself. Harshul, what are you going to teach us?